All right, so yeah, thanks everyone for joining us. Obviously, what we wanted to go over today was a little bit more about Medicare. It's in this time of year, it becomes a hot button topic and a very bad if you don't have a little bit of guidance in how all of this works. So we're going to go over today not necessarily any specific plans or any plan specifics for that matter, but more so how the basics of Medicare works, what your options are on a higher level. And then if it's
Ryan, I
something
hate to
that
interrupt you. It's just we're having some difficulty hearing you if we're on speakerphone or I'm not sure.
no. Is that any better?
Yes, it is.
Okay. So basically what we're looking at is trying to give an idea of the different steps and the things that are available on the Medicare side of things. So as we go through these slides, obviously post any questions you might have and we'll take a Q&A at the end. But hopefully this makes a little bit clearer on what you need to do with the coming open enrollment period. And obviously happy to provide any help that we can along the way. Okay. So, a little bit about myself. I've been in this business for about 14 years. I am a independent agent licensed with the Medicare to sell Medicare products and appointed with a lot of major carriers in the area. Kind of give you a bit more of an impartial view on different carrier options. Again, we're not going to get into a lot of that today, but just gives a little background of how I work and what I do. A little bit of the exciting fine print here that a lot of this is based off of 2018 data, because 2019 data doesn't come out until October 1st is really when open enrollment starts. We'll go over that in a second. But there's some data that's out for 19, some data that's not. So there is a little bit of a asterisk next to some of it showing that it is based on 2018, and we're projecting 2019. But this is not meant to be kind of a be-all, end-all for Medicare information for 19. This should be a little bit more due diligence done when October 1st comes around to review that data either personally or with my assistant. So Medicare is health insurance. Essentially, it's kind of a very simplified way to put it for people over 65, people under 65 with certain disabilities, and people of any age with end-stage renal disease, permanent kidney failure requiring dialysis or a kidney transplant. Original Medicare is comprised of two parts. You see on your Medicare card when you do join Medicare, you get that red, white, and blue card. It's Part A and Part B. Part A is the hospitalization side of things, your major medical, if you will. Covers the inpatient care in hospitals, skilled nursing, hospice, and home health care. Out-of-pockets on this side of things for 2018, again, 2019 should be available shortly. There's a $1340 deductible. That's actually each benefit period in the sense of each hospitalization. So it's a per occurrence benefit, which is a little bit different. When you think about deductible on a health plan, it's a per year. When you think about deductible on a Medicare plan, it's per occurrence. So a little bit different thing to consider there. And then days 1 through 60 are covered after that deductible for hospitalization, but days 61 through 90, days 91 and beyond, you have some out-of-pocket exposure there you might be subject to. Part B is your outpatient side of things. So whereas Part A is covering inpatient hospitalizations, Part B is outpatient medical, doctor's visits, testing, and some of the other things like home health care, durable medical equipment, and preventative services that aren't covered by outside sources, which we'll talk about later. Out of pocket for the insurance for 2018 on this front is $183 per year Part B deductible. That's again towards all of those smaller outpatient services. And then a lot of different areas that we're going to go over a little more in detail. There's a 20% out of pocket for the insured. So think about this a little bit more like an 80-20 plan. That's kind of a simplified way to look at it. When you talk about Part B, doctor's visits, outpatient testing, outpatient ER visits, those are all going to be 20% out of pocket to the insured if we don't have anything else to complement this coverage in place. Premiums for original Medicare Part A is usually going to be no cost. As long as you have 40 quarters into Social Security, there's no cost associated with that care. There is a cost, as you can see in the 2 bullet points below, if you have less than 30 quarters or 30 to 39 quarters into Social Security, there is going to be a premium associated with that piece of the coverage. Part B, same thing, it's going to be $134 a month is the standard rate for 2018. There is a uptick based on an income adjustment table. We're going to look at that in a second, but it's based on a 2-year look back, which is a little bit counterintuitive. It's not something you would think that they would do, but it's 2018 is based on 2016. As we go into 2019, that modified adjusted gross income is going to dictate the 2017 is going to be dictated by 2017 income. So we look at this table. This is pretty much the adjustments that we're looking at, and this is again 2018 data, but we're looking at single filing less than 85,000 or joint filing less than 170,000. You're going to be at that $134 a month base rate. If you start to creep beyond that, as far as your 2-year look back on your modified adjusted gross income, you see that Part B premium will adjust all the way up to that top rating class of over 160 for an individual, or over 320 for a joint filing, will be a $428.50 Part B premium. Again, that might change slightly, but it gives you a rough idea of the tables. So significant costs associated with changes in income, but obviously the idea is that they're trying to subsidize care for the people that would need that lower cost, and people that have that income coming in still, and even in retirement or even in post 65 time frame, maybe you're still working. The idea is that you pay a little bit more for that. There is a late enrollment penalty for Part B, so they're expecting you to sign up either when you turn 65, the first of the month of your 65th birthday, or when you lose, say you have a special election period like losing coverage through work. That's when you would sign up for that. At that point would be, when you have that option of like leaving a work plan and you're deferring Part B because you have that work plan in place. Now you've lost that health coverage. Medicare system is expecting you to sign up for that plan once that Part B is available to you without any redundancy. So the monthly premium may go up 10% for each full 12-month period that you could have had Part B but did not sign up for it. And you also may have to wait for what's called the general enrollment period, which is January 1st to March 31st, to enroll in Part B, which then starts on July 1st of the fall of that year. So it's kind of an extended period where you can't just flip the switch. If you miss that enrollment period for either the general public as a whole turning 65, or for you personally because you lost your work coverage, you're going to have that late enrollment penalty, and it could be a little bit of a delay before you have the coverage in place as well. What do we do beyond original Medicare is usually kind of the next topic of discussion, because we looked at Medicare and we said, all right, it does a lot of things well. It covers you to a good extent with a lot of different services in a lot of different areas, but there is that 20% out of pocket in a lot of those areas. There are deductibles in Part A and Part B. There's no clearly defined out-of-pocket maximum on that coverage, and there's no built-in prescription plan on that coverage either. So there's a lot of little things that in most cases people are going to look to say, all right, how do we complement or supplement this coverage? How do we look at maybe making these a little bit more comprehensive? And I think this is where it gets confusing for a lot of people, but I think really you kind of boil it down to becoming just a simple fork in the road, where there's two major ways you can modify or complement your Medicare coverage, and that would be a supplement plan or an advantage plan. So you look at this kind of easy to read chart here. You have Part A and Part B in original Medicare. You go to a supplement plan, and it's going to basically be filling in gaps. And you go to an advantage plan, it's more like a replacement. We're going to go into this in depth. But these are really the two major topics we're going to go over, is how do you complement this coverage. You do a supplement plan with a Part D coverage for prescriptions, or you do an advantage plan, which is otherwise known, just to confuse things further, as a Part C plan. So you get A and B, and then we're going to go over C and D. This will be a little clearer once we get through it all, I promise. But that's just the terminology that they use. So the first thing we're going to go over is a Medicare supplement. A supplement plan is what's considered as a complement to original Medicare. Now, these are sold by private companies. They can pay some or all of the healthcare costs that original Medicare does not cover. So you can have a Medicare supplement plan that covers certain components of what Medicare does not pick up, or it's going to be a supplement plan that covers everything Medicare doesn't pick up. Assuming that a lot of the people on this call are based out of Massachusetts, the Massachusetts versions of these is really only two major types. There's what's called the core plan, which covers everything except the deductibles on Part A and Part B. And then there's a Supplement 1 plan, which will essentially cover every medical expense that's Medicare approved, that a Medicare plan, that the original Medicare does not pick up, will be picked up by the supplement plan. So you can essentially cover all your potential out-of-pocket expenses through either original Medicare or through the supplement plan. Of course, you have a premium that you pay to have that luxury there, but it is nice to know that there is that possibility to have all of your medical care covered, all Medicare-approved services would be covered with no out-of-pocket to you as long as you pay that premium on your Medicare supplement and you have the original Medicare in place. You're going to have that possibility. There will also be some stuff that's covered that original Medicare does not get into. Sometimes there's fitness reimbursement, medical care outside of the United States is usually a big one to think about. Vision, hearing, dental benefits are sometimes part of these packages we can look at, but obviously the goal, for the most part, is just to cover the out-of-pocket exposure on the health side. You must have Part A and Part B to enroll. The Part B premium is still paid. That $134 a month base or whatever your income adjusted amount is would still be paid to Medicare to have that original Medicare in place. One of the big features of a Medicare supplement, and one of the reasons that's a popular approach to the people that go that way, is because they have access to anyone that participates, I guess is the terminology they like to use, in original Medicare, meaning that any doctor that takes Medicare is going to take your Medicare supplement plan. It doesn't really even matter all that much outside of a customer service side of things. It doesn't really matter too much who your carrier is for the Medicare supplement because the network is anyone that takes Medicare, which is a really nice thing. Any doctor, any hospital that's Medicare participatory, which is kind of tough to find doctors and hospitals that don't take Medicare these days, they would be covered under a Medicare supplement plan of your choosing. One caveat on the supplement, where there's always a catch a little bit here, right? Everything that is medical claims is covered by the supplement, but it does not include a base prescription plan. Prescription plan has to be purchased separately, and that's why you saw in that original concept diagram a supplement with a Part D. So we're coupling that with a prescription plan. Prescription plan, it can come, but it's not always coming from the same carrier. So you would have a separate prescription plan, and you got to make sure you're either aware of when you're doing this yourself, if you're working with someone that's helping you, of what is going where, because essentially you're going to have three components with the Medicare supplement model. You'll have the Part B premium, which is either deducted from Social Security if you're taking Social Security, or it's billed to you on a quarterly basis directly to you. You're going to have the Medicare supplement premium, which is basically paying to the Medicare supplement carrier, which is billed monthly. And then you'll have the Part D premium, which is your cost for your medication coverage, which that will be a separate charge to whatever carrier that is. So there's three components. Again, the positive here is that it's accessible to every doctor that takes Medicare, every hospital takes Medicare. You can get a plan up to and including plans that will cover 100% of all medical claims that are Medicare-approved services. And you can basically have a plan that's kind of, of a comprehensive nature, with just a prescription, everything except the prescriptions, copays are covered by your plan. The flip side of that is it's obviously going to be a little bit more expensive to have those coverages. We're not going to go over individual pricing on components because there's going to be such a wide range depending on what state you're in and what type of plan you're looking for. But it will be more expensive to have a supplement plan, but you're paying for the luxury of having that significant uptick in coverage and access. Part D coverage is going to be that standalone component when the Medicare supplement equation. Plans can vary greatly on design and premiums. This is very important. When you look at a formulary list, what drugs are covered and at what tier they're covered at in a prescription plan will vary significantly from company to company, and from even within a company from one plan to another. So when you have insurance providers offering 3 or 4 plans, they'll be very different. One will work extremely well for you, and one won't necessarily work as well for someone else who has different medications or even goes to a different place to pick up their medications. Little things like that can affect which prescription plan is going to be best for you. Some plans will have a deductible, others may not. The deductible cap for 2019 will be $415. That's the highest deductible a plan can have on it. Average monthly premium for a basic drug plan under Part D drops to $32.50 in 2019. So it's a $1.09 reduction in average premium across the country for a Part D plan this year. So prices are going the right direction on those. Even with that, obviously with the extra dollar included in there regardless, it doesn't seem to be the biggest factor financially in the equation. A lot bigger than the premiums on a Part D plan are the out-of-pocket expenses of your personal medications. And so in those situations, we try not to overthink this. You just take the list of medications, the dosages, the frequency at which those medications are taken, and the location at which you pick up those medications. We're taking all that information, entering it into a Medicare database, and we're basically looking at a combination of which plan is going to be the best fit for you personally based on your medication list and where you pick them up. There's going to be a projection of an out-of-pocket cost. Assuming that your medication list doesn't change, there's going to be a projection month to month of what your out-of-pocket will be in that particular phase of the year, and we'll look at a total out-of-pocket cost for the remaining part of that year and say, here's the medication plan that we've identified as having the lowest out-of-pocket exposure to you. There will be star ratings, and they'll, to show strengths of coverages, and there will be different carriers that some people will feel more comfortable with than others. So there's more factors that come into this than just the out-of-pocket. But I'd say that is the biggest factor in picking the right prescription plan. It's not necessarily the premium, not necessarily the carrier, but it's how much out-of-pocket cost are you going to incur month to month and through the entire year for your medications, for your prescriptions. Obviously, there's going to be changes to medications throughout the year, and we want to make sure that we're accounting for that possibility with our selection as well. But there might be, 2 or 3 that shoot out to the top as the lowest out-of-pocket exposure potential, and those are the ones we focus our discussions on usually, rather than comparing 30 different plans. The prescription list helps to narrow that down pretty quickly. We talk about the out-of-pocket, and you notice as I'm describing, I'm talking about month to month during different phases of the year. The reason for that is a prescription plan on Medicare is structured very differently than a prescription plan on a health plan. So if you're just coming into the Medicare world this year, it's going to be something you want to pay attention to. Medicare prescription coverage has 4 different phases. Some plans, not all, but some plans will have a deductible. We talked about that $415 max for a deductible. It can be anywhere from 0 up to $415. So if your plan has the deductible, of course, that's the first phase. You're paying into that deductible until you hit that with your out-of-pocket on your medications. Whether you do or don't have a deductible, the next phase is the initial coverage phase. Think of this one as the most akin to what a health plan does, where they have tiers based on the type of medication and the cost of that medication. So you'll have, most of the plans now will have 5 tiers. So you'll have preferred generics, non-preferred generics, preferred brand names, non-preferred brand names, and then specialty medications. And they'll price out each of these medication as a maximum copay if they're in that particular tier. So that's similar to what you've seen on a health plan in the past if you're just coming into Medicare. Where it can be a little bit different is there is a definitive list of preferred pharmacies and base pharmacies where you're going to pay a lot less on some of these plans for preferred pharmacies and getting your prescriptions at those facilities versus the regular retail types of pharmacies versus a mail order service. So you'll have kind of 3 different types of pricing structures depending on where you're picking up your medications. As I mentioned earlier, it might have sounded a little crazy to say even where you pick up medications can affect which medication plan makes the most sense, but this is why. Is because there's a preferred list each provider has, and the preferred list is different. Whereas one provider might think Walgreens is someone that they worked out a really, really great, copay system with. The other provider might just have them as a base provider, and it might be a lot more expensive to go to Walgreens versus they might have CVS on their preferred list. And so it's important to identify what your preferred pharmacy is in this process. In any event, once you get through that initial coverage stage, you get to the coverage gap, which people have previously in slang terms referred to as the donut hole. You may have heard that in the past, this is essentially what that's representing, which is what your total drug cost reached a threshold of in 2019, $38.20 for the year. You pay no more than 51% of the total cost for generics or 40% of the total cost for brand names. And so when we do this due diligence and we look at the cost of medications, this is why that medication list is so important, because it's going to tell us how quickly you will get to, if you will ever reach, or how quickly you'll get to the coverage gap. And beyond that, will you ever come out of the coverage gap into the next stage, which is the catastrophic stage? So after your yearly out-of-pocket drug costs reach another threshold, which is $5,100 in 2019, you pay the greater of 5% of the cost for generics, or 5% of the cost overall, which is either $3.40, let's just say 2019, I apologize, it's a typo, $3.40 in 2019 for generic, or $8.50 for a brand name. So you go through these four phases, and if you talk to a friend or a colleague or a family member, and they might say, I have this prescription plan, it's fantastic. I would recommend it highly. I think this is what you should do. And they don't know what your prescription list looks like. They could be really doing you a disservice. They're trying to help and talking about their experience. But if you have just one medication different than what they have, or if you go to a different pharmacy than they have, or if you even start Medicare like halfway through the year and it's a different spot in the year than they had a full year, these things all affect what works for you personally. So it's nice to have people give you advice on what plans will work, but I would highly recommend you either do the due diligence yourself, or if you speak to someone licensed in Medicare like myself, we'll take you through that due diligence of what's going to work for you personally based on your current health and your current medications. Now, just like we talked about for Part B, there is a late enrollment penalty for Part D. One of the common conversations I have with Medicare enrollees is, I don't have any medications. I don't think I'm going to get prescription coverage right now. The Medicare system, the Center for Medicare Services, they've thought of this. So they've kind of accounted for this in this late enrollment penalty. What they're trying to avoid is people avoiding Part D coverage when they don't have prescriptions, and then picking up Part D coverage when they all of a sudden have a very expensive medication. If you don't spread out that cost over the course of healthy and medication-laden people, you end up with a much more expensive plan structure. So they basically have it in place where they want you to have that Part D maintained throughout, even if you don't have any medications. We're talking about the lowest cost Part D plans being somewhere in the neighborhood of $12 a month. They're not expensive. They're not huge. So you want to avoid this penalty, because what it is a late enrollment penalty if you're after 63 days, more than 63 days after your initial enrollment period is over, you go without a Part D plan or a Medicare Advantage plan that includes prescription coverage, we're going to look at in a second, or another Medicare plan that offers prescription coverage, or credible prescription coverage through like a health plan through work. That caveat situation we talked about before, where you have prescription coverage provided through work and you're still working, that's going to avoid this late enrollment penalty if you were to get it later because you didn't actually have a need for it at the time and you weren't avoiding it, you had it elsewhere. The penalty is calculated by multiplying 1% of the national base premium, which is that $32.50 in 2019, times the number of full uncovered months without Part D or creditable coverage, rounded to the nearest 10 cents, and added to your monthly premium. This is a base penalty that continues for life. So, as ludicrous as that sounds, if you go, a year and then the second year around you decide you want Part D coverage, now you're talking about a 12% increase, based on that calculation. So say, $3.25 times 12 months, that's going to be added to your Part D premium every month, and that's going to be adjusted for that national average every year to have your late enrollment penalty. So it's just not worth trying to avoid. It'd be very, very rare where I could say someone could justify it. The only time you could really say that it would work is if you're never going to get Part D coverage, but who's going to ever know whether that applies to them or not? I mean, your situation could change very quickly in your needs for medications. If you avoid it for a couple of years, it's almost like you end up, it only really works in your favor if you avoid it for life, which is very unpredictable and it would be tough to gauge. But that's the only way you don't end up paying that late enrollment penalty, because once you enroll, they're calculating all that time you missed and adding it onto the base. There is an income adjustment to Part D as well. We talked about the Part B. Part D is not nearly a significant income adjustment, but it does use a very similar table. You look at, the highest being, it would be $77 a month added to your monthly premium on your prescription plan. This income adjustment is billed as part of your original Medicare expense, whether it's billed through Social Security or billed directly to you from Social Security. That's where you'll see this. So, again, we talked about it being, $12, $20, $30 a month, pretty, $32.50 average premium. Not going to be super expensive, but if you do have a significant income, you can see that go up quite a bit. And keep in mind, these are adjustments that are done in the short term. So, like if you had a change where all of a sudden in 2018 you stopped working, you retired, when you get to 2020, your income adjustments will be based off of that income, and you might lose that adjustment entirely. You wouldn't necessarily have that apply to you anymore, and now all of a sudden it's much more affordable again. Conversation comes up a lot with these income adjustments is what happens if I just stopped working and my income was there a couple of years ago, but I don't think I should have to pay this big extra premium. I don't have this income now, and I don't really feel like this is justified. There is an appeal process. There's an appeal form you can fill out, and I have seen people get approved for it. It would depend on the individual situation, but if you feel the adjustments are unjust, you can certainly appeal that and so you can get approved the removal of those income adjustments. We talk about the enrollment periods. Your initial enrollment period is when you're newly eligible. This is when you talk about that Part A and B kicking in. That Part D becomes that initial enrollment period. And it's basically going to be a 7-month period. It's going to be 3 months before, the month of, and 3 months after your initial enrollment, which is usually a 65th birthday, but not always. Say in this example, if it was that situation, it would be 3 months before that 65th birthday, the month of, and then 3 months after. If Part B is delayed, it's the same thing. You're going to be 3 months before and 3 months after. Say you kept your work plan and you delayed Part B for 2 years, your 7-month window comes when that work plan ends, and now you're getting into that Medicare world. We talked about Medicare supplements. We talked about when to enroll in original Medicare. The other way to go outside of a Medicare supplement is a Medicare Advantage plan. So think about, the very simplified way I try and describe this is think about a Medicare supplement as kind of the set it and forget it approach, where you pay a little bit more premium to have everything covered and have every facility and every doctor accessible to you. And that's a complement to original Medicare, right? We talked about that. Medicare Advantage is it different in the sense it's considered a replacement of original Medicare. So these are again offered by private carriers, must be entitled to Part A and enrolled in Part B, permanently reside in that service area of that plan, and not have end-stage renal disorder, end-stage renal disease to qualify you for coverage. It's meant to be a replacement with enhancements. So these plans, they have to be at or better than original Medicare in every area. So they're basically saying that we're going to give this private carrier, like, in Massachusetts, we look at Blue Cross and Tufts and Fallon and Harvard Pilgrim and United. These are the carriers that we're referring to when they say private carrier. So rather than Center for Medicare Services administering your care, you're now putting your care in the hands of a private carrier and saying they can be as low as $0 additional. You still pay that Part B premium, but you might pay nothing extra to have this Advantage plan, and it might give you everything you need. It's just a question of personal needs, and a lot of times, obviously, it's driven off a budget as well because these are low-cost to no-cost type of plans. Now, the question comes up a lot, of course, how do they get away with charging nothing for these plans? The government will pay these private carriers a stipend to provide you with the Medicare coverage and to administer and manage that care. So the government is providing this private carrier with a certain amount of money every year to give you that to kind of take the administration off of their hands, and they're the ones that are now fully in charge of managing your care. So it's a little counterintuitive to say you're still paying that Part B premium. The government is still getting involved to a certain extent, but the carrier themselves is getting their pay, in terms of compensation from the government on the back end. So these plans are going to be low cost to no cost because they don't have to charge to the consumer because they're being paid by the government. It's a little bit different than some other things we've looked at for insurance, certainly, but it's a bit of a unique approach, and it does allow people that have either a limited budget or they're healthy and they're not too worried about kind of pay as you go expenses, a way to get some low cost coverage. Now, when I say worried about expenses, we're getting into that in a second, but just the bottom point here is important. So they offer extra coverage in a lot of these plans. They'll offer the original Medicare coverage with some enhancements. Then they'll offer things like vision and hearing and dental and gym reimbursement, things like that. We talk about the actual coverage itself on a Medicare Advantage. There are various types, HMO, PPO being the most prevalent, but there are also private fee-for-service plans, point-of-service plans. I can explain those further to anyone that has interest in these plans, but subject to the network of the specific carrier you obtain coverage from, that's important. We talked about the supplement plans being accessible at any doctor, any hospital that takes Medicare. The Advantage plan, now you are available to utilize any doctor, any hospital that takes that particular carrier. So if you choose a Harvard-Pilgrim plan, that carrier has to be in the Harvard-Pilgrim Medicare network. Or if it's a PFFS or POS plan, it's a little different. But let's say an HMO plan, which is the most prevalent, it's just like a health plan. Now that doctor, that hospital has to be in that network for you to use for care outside of any medical emergency. Important to verify availability of doctors and hospitals. We talked about in the prescription plan how it's important to verify that your prescriptions are covered properly and effectively on that Part D plan. Same with the Medicare Advantage plan for doctors. We have to make sure that your doctors that you absolutely want to make sure you maintain access to are covered by that Med Advantage plan. And so that's an important part of that due diligence process. You can look at a Med Advantage plan, it might look fantastic, but you go to your doctor and they say, sorry, we don't take this. You're up a creek and you might be outside of any sort of enrollment window that you can take advantage of at that point. And so you may have done yourself a disservice not doing the proper due diligence. And that's where people like myself can be of service to help you to make sure that that's not going to happen. There are also obviously some utilities available to you personally to make sure that doesn't happen as well. Just make sure you do that due diligence one way or the other. One big difference in the Medicare Advantage versus the supplement plan is most of the Advantage plans include the Part D coverage, whereas you're going to get it separately on the supplement and have it be another component. Everything's usually wrapped into the Advantage plan where that prescription coverage is part of the overall solution. Again, it's important this is still considered prescription coverage under that same model of like the different stages of care. So it's important to verify your medications, dosage, frequency, and access point with each plan to make sure that you're going to have a projection and a reasonable expectation of what your costs will be, and you're selecting a plan off of those expectations. These plans are more of a pay-as-you-go approach. So, that's my simplified, personal monikers for them. The supplement will be the set it and forget it approach, and the Advantage will be the pay-as-you-go approach, because you're going to have it built like a traditional health plan where you have deductibles, co-pays, out-of-pocket maximums in different areas of care, and they're going to vary greatly from plan to plan. So if you have someone that uses a certain aspect of coverage more than another person, and again, you're getting that recommendation that this plan is fantastic, this carrier is fantastic, that may well be the case, but if your needs are different, your usage might be different, and therefore the plan that makes the most sense might be different as well. So it's important to be aware of that. Premiums can be deducted via check, EFT, or because an Advantage plan is actually part of the general Medicare system, it can be deducted from Social Security if you're taking Social Security, whereas a supplement plan cannot be. Supplement plans will be paid directly to the carrier by you as the consumer. So that's basically a high-level summary of the different options. Now it's a matter of like, when do you take advantage of these options? When do you get to review your options and make these choices? The reason we're doing this call this week is because next week starts what's called pre-AEP, which is essentially October 1st to October 15th, October 14th. So October 1st to the 14th is a time when you can review 2019 plan options, but you can't sign up for anything yet. They don't accept applications between the 1st and 14th, but you will have the avenues and the information available to you to review all of your options in 2019 during that span. When we hit October 15th, that's what's commonly referred to as AEP, Annual Enrollment Period, Annual Election Period, which is basically your time every year to change the design of your Medicare coverage. So 2019 plan reviews begin October 1st. 2019 coverage signups begin October 15th, and they go through to December 7th. Anything you do during that window takes effect on January 1st, 2019. So this is your opportunity to enroll or disenroll in a Medicare Advantage plan. This is your opportunity to, switch from a Medicare Advantage plan back to original Medicare so you can add a supplement plan on there. To switch your Part D coverage from one prescription plan to another. This is your time of the year to do all of this with an eye on 2019. You can apply for something, change your mind, apply for something else. It's the last enrollment request that you make during that period will be the enrollment request that takes effect. So it doesn't happen very often, but it's just an important little caveat to be aware of here, that if you apply for something on October 15th, and then you have some change in health or some second thoughts or whatever the case may be, you didn't get the proper guidance at the time, and then you do after that, and then November 1st, you go apply for something else. That November 1st plan is going to be the one that takes effect because that's the most recent application, most recent to the end of the AEP period. That's the one that's going to be the one they put in force. Outside of that annual period, which is more, the reason we're having this call now and the timing of it, we're focused on that period. There is going to be a special election period, of course. That's what we talked about before, where if you had a change of residence, if you had an involuntary loss of drug coverage, meaning you lost a job that was providing you with coverage, or you had a plan that left your state, gain or lose Medicaid, gaining or losing a subsidy. Again, going back to that example because it's the one that comes up the most, gaining or losing health insurance through an employer. That special election period is a period outside of those usual windows, the initial election period when you first get into Medicare, that annual period that comes up every year, that you have this option to get into, plan designs and plan changes or just initial plan selections because that special election period applies to you personally. There's a voluntary disenrollment period from January 1st to February 14th. This is actually changing as of 2019. It's going from January 1st to March 31st. You're going to have the option to switch from one Medicare Advantage plan to another during that period. So it's kind of another checkpoint to say you're having second thoughts of what you signed up for. You can basically go back and say, we're going to go from January, that plan you signed up for between October 15th and December 7th. Now, after January 1st, you get into it, you say, you know what, this isn't really working for me. You can go back and you can change the plan during that January, February, March time frame, and that's going to basically take effect the first of the following month. That new plan will kick in. So you have these involuntary disenrollments when you can you're disenrolled basically because you lost a certain thing that your provider moves outside of your enrollment area, or you lose your Part A and B eligibility. But the voluntary plan is going to become much more prevalent this year, where maybe you got a plan during that period that you thought was going to work and it doesn't. You have a checkpoint now that you can go back and change that or disenroll from it a little bit longer period than we had in the past to do so. That's what we call this OEP. And I should have looked at the next slide, a preview here, but that's what I was describing here. This is January 1st to March 31st. You can replace the prior voluntary disenrollment of January 1st through February 14th is going to change to January 1st to March 31st. You can make a one-time election to go to another Medicare Advantage or back to original Medicare. Individuals using this to make a change may coordinate the change to add or drop their prescription coverage. We talked about involuntary disenrollment. We know how that works already. That's essentially what we have for this Medicare discussion. We'll go back to this, and we'll go back to this in a second. But first thing we want to do is go over any questions or questions you guys had in relation to that presentation. We went through a lot of information. It's certainly not meant to be, again, the be-all, end-all of why you sign up for a certain plan. We haven't gone into any plan specifics. But if you have any questions on the overall structure of Medicare and how any of this works, fire away. And my contact info is here if you have any further questions about, help for you personally or specific information. I'm happy to help you there. But Medicare regulations mean that you have to reach out to me, not vice versa. And this is my contact information to do so.
Amanda, I think you were going to read any of the questions that you received.
Yes, sorry about that. We do have a couple here. Just as a reminder, using the question bar here on your taskbar, please feel free to go ahead and enter those. I do have a couple, so we will get to them. If perhaps Brian does not get to them in the essence of time here, since it's 12:47, Jamie or myself will reach out to you to make sure your question gets answered. So the first question that I have here is, if I'm still working and have insurance through my employer, do I have to elect Part B? I hear that there are penalties if I sign up late.
No, that's one of those special conditions there where you don't have to have Part B. Part B is a bit redundant to a lot of all of really employer health insurance coverage. If it's an ACA compliant plan, it's a redundant piece. And so what they don't want you to have you do is paying for your health insurance and paying for Part B at the same time. And so that's where you see a lot of people defer Part B. And if you're deferring it just because you don't want it, that's when you get that late enrollment penalty. If you're deferring it because you have creditable coverage elsewhere, that's going to be, eliminating the possibility of that penalty. As long as you sign up for Part B when you lose that coverage, there's no penalty associated with that situation.
The next question I have, Brian, is if I claim Social Security benefits, does that automatically sign me up for Medicare Part A?
Yeah, if you claim Social Security benefits, what they're going to do is as you reach your 65th birthday and that 90-day window starts, you're going to get a card in the mail, which is going to be a Part A and Part B effective date of that first of the month of your 65th birthday. Now, at that point, that's your checkpoint to say if you want to defer Part B, you have to either call them, you call 100 Medicare, you go to ssa.gov, or you go to the local Social Security office, and you say, I want to defer my Part B election. So before it goes into place, you make that election to that statement to them, you want to defer the election, and then you would just keep Part A, and then you could go back and re-enroll in Part B down the road. But if you're enrolled in Social Security, they're going to have you enrolled in A and B automatically as of the first of the month, assuming that that's what you want. So if that's not what you want, you have to proactively make that change before that first of the month of your 65th birthday, or whenever your election date, I should say. I should assume that's every situation. That's most.
Okay, looks like we just have one more question, Brian. Are you available to help families navigate Medicare choices? And if so, how do you get paid?
So the carriers pay brokers like myself to assist you with understanding your options, getting you signed up for a plan, and making sure that you're understanding what your responsibilities are going to be once you're on that plan. So it cuts down on their customer service costs to have someone like myself assisting you, because you're getting in the right plan from the start, and your expectations are set properly from the start as far as out-of-pocket costs and network availability and things like that. So certainly available to help with any individual situation. Anyone on the call that wants assistance, I'm happy to assist in talking about your options and finding the plan that might make the most sense for you. The contact information should be on the screen now still, I believe. Just feel free to reach out either via phone or email, and I'm happy to set a time with you to do so.
Thank you so much, Brian, for joining us today. Just a reminder to all of our attendees, if you'd like to join our upcoming webinar, Brian showed the screen already, you can just go to our website, www.stonehearthcapital.com. Chris Gauthier is our Chief Investment Officer. He'll be doing his CIO's Corner quarterly update next month on Monday, October 29th at noon. And then we have Essential Strategies for a Successful Retirement with Jamie on Thursday, November 29th at 3. And then Thinking About or Recently Divorced, Think Financially, Not Emotionally. That'll be with our Senior Financial Advisor, David Giuliano, on Tuesday, December 18th at at 12, and we'll be coming out soon with our 2019 webinar series, so make sure you look out for that. Thanks again, Brian. It was very informative and helpful, and we hope everyone has a great day.
Yeah, I apologize for initial technical difficulties, but thanks for your time.
Thanks, Brian. Take care, everybody.
Bye.